We envision a movement.
We envision a movement.
We envision a movement of God's people.
A movement of God's people.
God's people who choose daily.
Who choose daily to promote healing
in marginalized communities in the name of Jesus.
In the name of Jesus.
In the name of Jesus.
I think this is important because CCHF has grown a lot and it's morphed a whole lot, and it's on a growth path now. We're seeing a lot of just a lot of people that are showing an interest, wanting to be a part of sort of a community that is supportive of one another to live out the gospel through healthcare among our most vulnerable neighbors. And I think it's important to understand our past in order to really embrace what God has for us in the future. And I think you're going to help us do that some today. So good. I appreciate that. With that said, we were just talking over a little bit earlier about how after you left CCHF, there were several iterations, but one of the things that happened was in the early 2000s, there was a large grant that they received by the federal government to help train people how to start health centers. Mm-hmm. And then when I came to CCHF, it was right after that grant had stopped and after that program had stopped. But the only history I had of CCHF was all about starting health centers. But when you were with CCHF, it wasn't like that at all. Can you tell us a little bit about what CCHF was like when you first came on?
When I was with CCHF in the early years, there were probably 40 or so community health centers around the country. It was a small organization. We became a membership organization right after I started, and we had started out with 450 members.
Yeah.
And grew from there. When I was with CCHF, the primary focus was on health and development, which is the periodic we published, and conferences, and then just the networking that happened within the organization. And that was probably, in the long run, the most important thing.
How did you connect with CCHF in the beginning?
So when we lived in Chicago, Libby was the business manager for Circle Family Care, which no longer exists. And she was actually the first employee for Lawndale Health Center. She was the business manager there. I knew nothing about CCHF. All I knew was these two clinics that we had been involved with. I got our blood test when we got married was at Circle Family Care with John Buran. So I was had decided to move to Philadelphia for a couple of reasons. One was I wanted to go back to graduate school, even though I was in my 30s then, to get an MBA in economic development. And Libby's father was dying of cancer, and we wanted to be around for that. He died about 10 months after we moved there. And when we moved, she was pregnant with our daughter. So when I was hired for CCHF, I was only hired, I thought it was like a publications gig. I was hired to work on health and development, and that was all. And Libby was hired to work on conferences, and that was all. And there was supposed to be somebody else doing all the other management kinds of things. Well, when I started with CCHF, CCHF was in a hole financially, really, really big hole. And so the person who was going to become the executive director basically said, I'm not going to be able to show up for a long time because there's no money. We started, and the 17 boxes arrived from Mississippi to Philadelphia on the train, picked them up, and that was all there was. Before moving to Philadelphia for CCHF, to work with CCHF, to go to graduate school and work for CCHF, the only person I knew who was a part of CCHF was Libby's former boss had been on the board of CCHF, but I didn't know what CCHF, I couldn't have told you what it was about. So it was kind of like I had no clue what I was getting into. The first year was pretty rough financially. We started on July the 1st. We didn't get paid till December because there was no money in the till. and it grew from there.
In Health and Development, which was a journal that CCHF, actually, I think that's what it really started as a journal, CCHF, more than anything else. They didn't do a conference until after the first we call it H&D, but after the first few H&Ds had come out, I think.
I can't answer that question because I just don't know. When I started with CCHF, there had been several conferences, and I don't know how many issues of H&D. It was like a.
Your 17 boxes were probably mostly overruns of H&Ds.
That was overruns of H&D. Yeah, they were. It was like a newspaper quality thing, and I'd been working in publishing at that point, and so I knew, the tricks of the trade, and began working with getting typography and finding a publisher and improving the quality of the paper, and hopefully improving the quality of the product from there. So
it became a very influential journal.
At the time, it was. I can remember calling someone about an article that he had been writing with me, and so I called, and his wife picked up the phone, and he said, well, he's just settling down to do one of his favorite activities, and that's to read H&D. We just arrived this morning, and he's settling down for the evening to read it. I thought that was pretty complimentary. So
what was like when you got an H&D and you opened it up? What were you seeing?
Well, the design of the periodical was for practitioners, and so it wasn't like an academic journal. It was, what do you do? How do you live? And so the majority of members, the articles were written by members. The vast majority were written by members. Many times they were people who said, I've never written anything before. And I said, we can take care of that. All we want is the heart. And then we can build an article around it. And so I edited stuff. We had another part-time editor who worked for me editing stuff. And it was a long process. I mean, it was not typical of working for a periodical where you send the article in, and people weren't just sending articles into us. That didn't happen. Yeah. I had to go out and solicit, and, find the people who had the goodies, find out who had something really that I thought needed to be heard, and broadcast to the world. And so that's what H&D was. We were. And actually, the book, Caring for the Least of These, that we did, that must have been in the 90s, was basically the old goodies from Health and Development. We packaged them up, and in the next volume that we did was Upholding the Vision, which is more articles that we pulled right out of H&D and used that for the second book.
How did you find the folks? Like, you had to go solicit the articles. Mm-hmm. Who were the people that you were?
This is where the networking comes in.
Yeah.
I'd be having a conversation with somebody, and they'd say, this is what happened to me, or I hear through the vague grapevine that somebody was doing something special, and so you begin to get those. You put the pieces in your mind and say, how can we begin to shape that? That's where the articles came from. It was some of them came from conferences. We had two people who do a presentation at the conference, and then you begin to say, could we rework this in a way that we could use it for an article? So I'd write them back, and from the material we would begin to develop an article. That's where some of the material came from too.
Yeah. Who made up the CCHF community at that time? Because Lawndale was pretty new and very small. Mm-hmm. I mean, your wife was the first paid employee there.
When we left Chicago, there were 3 docs.
They had 3 docs at Lawndale. Yeah. Wow. Christ Community in Memphis, which is a fairly large, well-established CCHF. That hadn't even started.
Just getting started.
Esperanza in Philadelphia was brand new.
They had started fairly soon after we got to Philadelphia.
Yeah.
So the community, it was a really dispersed community in many ways, because you had people from different parts of the country. who would interact with each other. There wasn't like in Chicago right now, there's a lot of folks who are involved in CCHF, and so you have that kind of natural affinity because you're all working in the same community, in the same city at least. But we didn't used to have that, and so you have to connect people, from different places. And so if one person is beginning to think about doing something, they talk about maybe we need to look at what assets our community has, and if you connect them with somebody else, or I would help them or somebody else. I was connecting with somebody else and say, you really need to talk to this person here to figure out how they got going. When people would call up with questions about issues they were struggling with, the big thing for me was to begin to connect with somebody else who's at least a step or two farther down the road, and could be given some hints.
What kind of questions would people call you up?
Some of them were basic startup questions.
How to start a clinic, or there's how do I find a place for me to work, or like when you say start up.
So typically it was a situation where you have somebody who's in an area, who's been there for a while, has developed their own personal networks, and say, this is something that we really need to think about. And so those were the initial phone calls from, and we'd begin to hook them up. So there was be like a group in one city. I remember going down to Knoxville, and there were 3 doctors who had a private practice together. And they said, we're here in Knoxville, and we've got these connections with the communities. It'd be interesting if we could do something related to healthcare in this community that we're our neighboring community. And so they would call up and say, well, what do I need to do? How do you get these babies off the ground? What do how do you begin to develop this network? And so some of those questions I could work with, but a lot of them were just people I had to say, we need to talk to so-and-so here. And so to find out how they got involved and how they got started. Because it's actually more valuable for it to come from another practitioner than it is from, some air controller up there in the sky.
Yeah.
So that was really the networking that happened. The board at the time was a very tight network. They were from all over the place, but it was very clear the relationships were pretty deep because they really struggled together.
How big was your board?
About a dozen people.
Yeah.
Yeah. So
in the very early days of this, what's become kind of a movement, it's a modest movement. It's not gigantic, but in our tiny little sliver of, the behemoth of healthcare, it's not insignificant. And who were some of the people that stood out to you as folks who seemed to really represent the heart of what CCHF was trying to be?
I think the godmother of CCHF was Janelle Getches.
Yeah.
In Washington, D.C. Just an absolutely amazing woman. You've got J.D. Miller down in Everett, Kentucky. Art was a young upstart at the time.
Art Jones,
yeah.
In Chicago.
Yeah. There were also other people like Carolyn Klaus in Philadelphia, Jan and Bob Williams in Denver. Yeah, these are people who were, all of these places were fairly young. Had
Crossroads in Cincinnati started? Sally Stewart, were they up and going by then, or?
Chuck Schubert was in a residency when they were getting going, and I was down there. Wonderful people. Her name used to be Sally Barney, but yeah.
I think it is interesting because almost everybody's name that you mentioned is still involved at some level with what this is all about. After 40-something years. Yeah, 40, at least 41 years, because you started in 83. This is 2024. So
yeah. One year we went on vacation with the folks from Crossroads. We went out to the Outer Banks with them for a week.
Fun.
Yeah, so those kinds of relationships were growing.
I haven't been invited to those kinds of things.
Well,
we don't know each other well. I only know you by reputation. It's a good reputation, by the way. People have said wonderful things about you guys. And I was sharing with you earlier that I never heard your name that I didn't hear Dave and Libby. You know,
Right.
it was always like you guys had this amazing marriage. You've been married for how many?
41 years. Yeah.
So, right. So, and you must have gotten married pretty soon, right before the CCHF world. So
we got married in, I started with CCHF in 85. We got married in 83 and started with CCHF 2 years later.
Oh, okay.
Yeah. So when we moved to Philadelphia, I was responsible for health and development.
Right.
And Libby was responsible for the annual conference. And
so they hired a newlywed couple and didn't pay them for 6 months.
Right. Well, we've been married 2 years.
Well, yeah.
We had a little bit of a track record.
Yeah.
So
when did you become a serious follower of Christ in your life? Did you grow up that way? Did you have a literal come to Jesus moment, or how did that happen?
So I grew up, I spent most of my growing up years in Rome, Italy. My father was a professor at Bible Institute. So I grew up in the church. From my father was a pastor at church before I even was born. Grew up overseas, and so it was part of the aura that I grew up under.
Right.
I wouldn't say that it was anything I decided to do at a nominal level until sometime in elementary school, probably when I was like 8 or 9 years old. I don't think it was a serious commitment until college. Because I think what happens is that when you grow up in a Christian family, you grow up in a church, you just, you hear all this stuff wash over you, but it wasn't mine.
Yeah.
It was what I was told I was supposed to believe. And it didn't become mine until I got to college.
Yeah. And when that happened, and where did you go to Wheaton?
Yeah, I went to Wheaton.
Yeah. So it was the Chicago thing, and you met Libby around that same time, or?
So Libby and I actually both graduated from Wheaton, but we never met, and we were never on campus at the same time.
Oh.
She started graduate school the year after I graduated as an undergrad. We actually both went to LaSalle Street Church at the same time. She went to the early service, and I went to the later service, and we never met. There was some pretty tumultuous transitions that were happening at the time in the church, and so a group of us decided to kind of step back and create a house church, and that's where I met her. So,
how cool is that? So I think it's cool just because of my own personal, like my wife and I are part of a house church now in inner city Memphis, and we have been for a number of years, and the relationships that you develop there are awesome.
Right.
You don't appreciate them until it begins to sort of break up, and as it breaks up, and you
realize how critical it was to you.
You realize how critical.
Right. And I think even in terms of CCHF, I think the relationships that you develop with the people you work with are so critical. I mean, you look at people who are involved in some very difficult situations. If you don't have someone you can fall back on and rely on and pick you up when you're crying, you need those people where you are. You can't rely on this national network of people. You need to find those kinds of sources of strength and reflection where you are. And I think that's where the community can become so important.
So how did Libby get involved with Circle and with Lawndale?
So we got married, and so she had been in Taiwan with the YMCA, and she came back to back to the States, and we had been corresponding pretty fervently during the year she was in Taiwan. And she came back. We decided to get married, and she began looking for a job. And you put out the word, and tell people that you're looking for work. And so this lady contacted her and says, I'm looking for a business manager for Circle Family Care. Are those the kind of skills that you can? And Libby says, they're not skills that I use all the time, but she said there's certainly something I've learned in the past. And so that's where her relationship with Circle came. then when a couple years later, or not even 2 years, a year and a half maybe, then Lawndale was getting started, and Art said, you've done this before. Would you be willing to come help us get off the ground? And so that's why she jumped ship and moved down to Lawndale.
Yeah.
So
when did you? I've read Caring for the Least of These. I've read a number of articles that you wrote during the H&D times and those kinds of things, and you have your own deep passion for how the gospel impacts or addresses poverty, and how Christians should be, how justice and dignity and all those kinds of things are wrapped up in the gospel. Was that something that was birthed in you during your time at Wheaton, or? So
that is something. It was actually kind of an accident that happened. I was a freshman at Wheaton, and there was this group in campus that was working with a tutoring program at LaSalle Street Church. And, I know how to read.
Yeah.
So maybe I can help. And so I got involved knowing nothing about inner city work or poverty in the United States, because I had grown up overseas. And so this is all brand new to me. In fact, I knew almost nothing about denominationalism. I thought everybody got along real well. I just didn't call them different names. But it turns out not to be true. Which is a real shock. And so I got involved in this tutoring thing, and I started working with a fourth grade kid, and kept a relationship with her going for 3 years while I was there, and began to ask a lot of questions. Why is it that I can go to this private college in the suburbs, in a very wealthy suburb of Chicago, and this kid that I'm working with, why is he stuck living in a housing project, it was Cabrini Green, one of the most notorious housing projects in the country. Why is he stuck in Cabrini Green at this school, Jenner Elementary School, which they can't keep teachers in the place? And why does he get stuck with this? I can use the education I got to go to college. That was no big deal. But he couldn't have those thoughts. He didn't have that possibility. The high school in the community was actually Cooley High, which became the movie Cooley High.
Yeah.
And the building has been gone for decades. Thank you, Jesus.
Yeah. Right.
So, but I began to ask questions. Why? How did this happen? Why do I have this privilege? And all these opportunities are just wide open for me. And Arthur wouldn't have those same choices. And, in some senses, we talk about right now how the primary determinant of your health is the zip code you're born in.
That's right. Yeah.
And it was very much, he happened to be born in this particular community to a single mom in a housing project. And I happened to be born in this, lower middle class family at the time. That we didn't have to worry about meals. We always had food on the table. And so that dichotomy is what began me thinking about, why is this injustice? Why is this dichotomy between what I have and what Arthur had? So that began the whole long thing of asking questions. After college, I worked in elementary school for 5 years. I taught kindergarten, and then first grade and second grade. And then after that, I went to work at Cook County Jail, teaching high school equivalency GED there for a while. And beginning, you begin to rub shoulders with people, and you begin to say, really the only difference between this person and me is where he was born and where I was born. And
he had no choice about that, and neither did you.
Neither did I.
Yeah.
We do have a choice about how we use it.
That's right.
And so, so that was part of my growing process.
Yeah. When you started with CCHF, and the big part of it was editing health and development and putting on a conference between you and Libby, like I've done some of that myself, and part of that, I think, is you just see what God has put on the table in front of you and try to capture some of that in people's stories or things that you bump into people about. But part of it, too, is you begin to, if you will, form a strategy, you know, like this is a value that we need to see reinforced, or this is a challenge that we need to help people through because I'm hearing about these challenges on a regular basis. I mean, what did you develop a strategy or a desire to see CCHF become something down the road, and how would you describe that?
Well, the way I would describe it is a little different than that. I would say that I saw myself as a vehicle with some skills and worked with a board that began to flesh out what did that vision look like. Because it wasn't my baby.
Right.
It's the board's baby. And so it was working with the board, beginning to say, you know, what are the unarticulated things that are going on in the back of your mind? You know, what are your dreams and aspirations, you know, in terms of this organization? And beginning to work through those and say, you know, well, you know, what should we be looking towards? It was very clear from the very beginning, you know, because many of the initial people involved with CCHF were young docs. The whole thing about, you know, reaching, you know, working with medical students or health profession students, I should say, was pretty central. So that's something there since the very beginning of saying, you know, unless we build this next generation, there's not going to be anybody who follows us. We are responsible for building next generation. And so that was, from the very beginning, was very, very important to the organization. I think the other part that was important to the organization is once people say this is kind of what they're thinking about, you know, how do you help move them down that road?
Yeah.
You know, there's many different models of things you can do, and you know, how do you begin to push them down, to not push them, but to help them take the next steps,
find their way,
yeah. Right?
What were some of the challenges that people were expressing back then? Typically now we see somebody who is maybe in their training years, and they, I think I've heard survey after survey say that, you know, somewhere between 70 and 80% of Christians who identify as their faith being important to them, that and they made it into medical school, if you ask them, why did you want to be a doctor, somewhere between 70 and 80% say, I really feel like God wants me to be a doctor to serve him missionally. But then there's all these challenges that they face going forward. What were some of the challenges back then?
Probably one of the biggest challenges was the education process itself.
Yeah.
I think what happens and it's not just unique to medical education, it's also in nursing, it's also in business, is what happens is those institutions want to create you in a certain model. And that model does not always include service in communities of the poor. If you look at where our teaching hospitals in the United States, they tend to use the poor as their victims while they're in training, but that's not usually where people go when they work. And so I think the whole medical and our whole education is modeled to not make this work. When you're, for example, when you're in residency and you're doing all night care, it's really hard to get to the point of seeing the humanity in somebody who wakes you up from your sleep because they're drunk and cranky. You know, that's really hard. But I think what they need to do is what you need to do is step back and say, this is not who I am. I am forced to live in this environment right now. This is not who I am. It's not who I want to be. But that's the struggle that I'm in. This is the place where I'm in right now. And in a sense, that's kind of paying your dues to get into the profession. But it shapes people's minds over time. It's no mistake that you find if you go to a medical school and interview first-year medical students, there isn't probably a soul that would say, you know, I'm going to make medicine to make a whole gob of money and live the good life.
Yeah,
you're not going to find. Okay, what you find though is people who genuinely say, you know, I had this experience with a doctor when I was young, and it was real important to me, and I saw the work he did, and I thought that I wanted to do that. Or maybe there was a family member who had a health crisis, and they saw how the medical establishment interacted with that person. And they come with this sense of, this is, I can help people by doing this. Because, when people interact with the health professional, many times it's at a very critical point, and they're struggling not over even just with the medical stuff, but it's also the other stuff that comes to the fore when that happens. And so I think most of the people, I would say probably the vast majority, come to healthcare education with those kind of things in the background. But what happens along the way is they get disabused of that notion through the medical education process, and then you've got the whole thing called debt. And it is overwhelming. There's no other way to put it. You graduate with over $100,000 in debt, that's going to limit your options pretty quickly.
Well, that was 40 years ago. It's over $400,000 in debt now.
I stand corrected. The other thing that I think that's also happened is the model of medicine has changed. The whole thing, it used to be, you went to see your family physician when you were a kid, and you might see them in a grocery store. They were part of the community.
Right.
That model no longer exists. I go in, when I had my rotator cuff gone, went to see the surgeon. He told me what he was going to do. He said hi to me the morning of the surgery. I never saw the guy again in my life, even though I wrote him a nice letter at the end saying thank you for it. So I think what's happened is in some ways healthcare has come to the situation of thinking in terms of, this is I'm not Dave Caes. I'm the guy with the busted shoulder.
That's right. You're the shoulder guy.
He's the shoulder guy, and he's fixing my shoulder.
Yeah.
And that's all he does. That's all he cares about. He only cares about fixing my shoulder. And so I think what happens is that we've lost, in some sense, kind of like a more holistic vision of what health is.
Yeah.
And I really think, and in medical education and healthcare education as a whole, really seeks to disabuse you of that notion. When you're in nursing school, there's this they try to instill this infatuation with electronics. This is all the things that can do.
Right.
Okay. So I think, in some sense, is the folks that are in CCHF have an opportunity to turn back the hands of time and say, we're not just dealing with this person and their cough, or their, cranky personality, whatever it is. But this is a chance to look at people as individuals, as people created in the image of God.
Yeah.
And say, how can I honor God when I work with this person? So I think that's where the struggle is from my end. And it's this struggle that's gone on for decades, but it's also something I think is much more acute now. And that's where I see the CCHF model is this emphasis on working with individuals and meeting them where they're at and looking at, what are the other things that are going on. I can remember sitting down and talking to Janelle Getches years ago. And she told me when she was working at Columbia Road, she says, I refuse to go into my exam room to see the patient unless I know there's a social worker available on staff.
Wow.
At the time. And there's all kinds of stories like that of where it isn't the health issue that has arisen is a outgrowth of something else that's going on in their life. And you fix something else. I still remember the story that Janelle called me years later. She said, I had a woman in my exam room. She had really bad hypertension. So I said, this seems to be new. She said, yeah. She says, it's new. And she said, well, what's going on in your life? And she said, well, my daughter had a baby. She's living with me in her apartment. The electricity got turned off. And the only way I can keep my newborn granddaughter home is by opening the door of the oven, turning on the oven, and putting my granddaughter on a chair.
Yeah.
Okay. So in my medical model that we know now, you throw the hypertensive at somebody and kiss him goodbye. Well, you don't kiss him. You kick him out the door. Well, Janelle said, well, I had to go back and say, well, why does this woman not have heat in her house? It's because something happened with the electrical company. She hadn't paid her bill. So she said she cut loose her social worker on a situation. The lady came back for a checkup a month later, and there was no hypertension.
She had heat.
She had heat. She didn't have to. She wasn't stressed out completely by the fact that her granddaughter, was living in a house with no heat. Yeah. So I think in CCHF, I think folks are in a position to begin to intervene not just medically or in health of someone, but also begin to take a step back and say, what's going on here? Why is this happening?
Yeah. But when you guys started, people that wanted to do this kind of thing, that were thinking, I want to apply my faith in this way, almost all of them ended up having to work in a secular setting. And I know that you and Libby ended up, y'all have spent the rest of your lives really working, well, you in particular, in secular settings. You worked in the behavioral health industry or ministry or whatever you want to call it out in Fresno, California. And then the last how many years in...
The last decade was spent in the public health department here in Madison.
Yeah. So how can CCHF support and encourage people who are doing what they're doing out of a sense of calling to serve Christ and to live out the gospel, but they're doing it in secular settings?
I think one of the things that is endemic to this environment is to say, this is the way you've got to do it. What happens is that we find something that works in our lives, and we say, this is the way to do it, and it doesn't work all the way for other people. We're very individual, and the situations we're working at are very diverse. But I think one of the things that I've noticed that's pretty broad-based is that there are allies in these communities that we get so wrapped up in our own stuff that we miss. And we don't understand that we can build relationships. For example, I worked with public health for the last decade of my life. There were some incredible people working in public health. And when I was there, the health department was beginning to work on issues of justice, looking at food deserts. Why are there food deserts? Is there some way that we can manipulate the city to begin to look at, can we use some tax policy to encourage a grocery store to set up in an underserved community? So those people are there. But I think what happens is that we need to set aside the fact that we're Christian and they're not, although there are a lot of Christians in those organizations, that we can develop alliances with those people. For example, here in Madison, there's an FQHC that we developed a relationship with the health department, and we paid them to do all the free dental health care they could do. And that was an alliance that we developed with it wasn't a Christian clinic, but it was an FQHC, a federally qualified health center. So you can develop those kinds of contractual relationships, but you can also deal with the relational things. Many times you have public health professionals who are in exactly the same communities CCHF people are working with. How do you develop those alliances? How do you develop alliances with the home health people who are going into people's homes?
Right.
How do you coordinate with them? Health departments as a whole tend not to have a very good rap. But the people who work in health departments didn't work in health departments because they wanted to screw people. They came in the health department because at one point in their lives they had a genuine thing say, I am doing this because I want to help people. Maybe not always from a Christian motivation.
Right.
But that's fine. They're working with the same people we're working with. And I think those alliances can be strong. And I think because we come at it from a Christian perspective, and maybe that organization doesn't, I think what we want to do is just push them away and realize that maybe there's resources that we can use and work with our people or our communities maybe more effectively. I mean, a classic example in my mind is if you're a community health center and you have somebody come in you find out has TB. Okay, what do you do?
Right.
You can't do that. You can't afford to do it because the meds are so high.
Right.
And that's an area where if you don't have a relationship with your public health department, you're going to get sunk on that one.
What I hear you saying really is, first off, there's on a systemic basis, there are things that we as Christians can do that says the gospel sees this as broken, and I can be a part of addressing the systemic brokenness in our health system. And then in terms of relational partnerships and things, we can be salt and light. We can be leaven of the kingdom. In those things, we can respect and do it in a respectful way, but set a culture that that smells like Jesus. Providers who are allowed to integrate their faith with their work, that they tend to be happier. They tend to contribute positively to the culture of the organization. They tend to have patients that are more compliant. They tend to have lower turnover. They tend to be willing to not complain about money as much, because there are higher motives for what they're doing. And I've shared with a number, I don't get an opportunity to see a lot of CEOs of secular FQHCs, but when I have, I've been able to share with them, if you have physicians who are in this out of a sense of calling, and they're wanting to do this in a way to serve Christ, there's a way to integrate spiritual care that's respectful, that is faithful to their, their faith and to the scriptures, but at the same time is going to have a positive impact on that organization. And so, I think that there are ways to do that. As I think I'm really fascinated by the earliest days of CCHF because the emphasis was not as much on clinics as it was on individuals trying to figure this out. And honestly, I think as I step away from leading CCHF, I think the next person behind me has an opportunity to recover what you guys were doing really well back in those days.
And to be honest about it, patients respond very differently when they see that this person genuinely cares and is asking other questions about their lives. They're no longer seen as the hypertensive who's coming in. They're seen as,
that's right.
David Caes who's coming in. This person has hypertension. He's a high stress position. Those kinds of interactions make a huge difference in terms of the patient interaction and their desire to be compliant. So I think, that's where the relationship building comes.
Yeah, we just need more training on that, and we need to kind of share that.
Probably just more experience.
Yeah, true.
So
that's right.
When I was in Philadelphia, I would spend 2 days or 2 half days a week working at a free clinic.
I heard this about you.
Yeah, so I was working at this free clinic 2 days a week, and essentially I was one of the 2 intake people there, and you begin to ask questions, and homeless people were generally brutally honest about what was going on in their lives. So what I can remember, one of this guy that came in who had AIDS. And this is back in the
80s,
in the early, very early years of AIDS. And the free clinic had a relationship with an infectious disease doc at one of the hospitals in town, one of the the saints in the system. And she would take we could pick up the phone and make an immediate appointment for our patients to go in for people with AIDS. And so the nurse practitioner was explaining, we've got some resources. And this patient said, I know that you don't have the latest technology and you don't have access to the latest meds, but you give a damn about me.
Yeah.
And I'm going to keep coming back. That's a completely different relationship.
Yeah. Well, listen, I want to respect our time, and I am really grateful for you being generous with your time today. Mm-hmm. I feel a bit ashamed that I haven't said this to you face to face before today, but I'm grateful for the years that you put in to help CCHF get established in the early days. And There's a passage of scripture in 1 Corinthians where Paul sort of warns the Corinthians, and he says, be careful how you build on another person's foundation. And then it goes on and says, there's only one foundation, and it's Jesus, and I get that, but I do think about that, and I hope that we've been faithful over the last 2 decades to build on foundations that were laid by you and the early founders, the
early
dreamers and stakeholders of CCHF. So maybe we can get you and Libby to come back to a conference sometime. That would be a blast. You'd love it. You'd love it. But pray for us. This it's growing. I think the seeds that you guys sowed 4 decades ago are germinating, and they're growing, and they're now seed bearing, and the growth has been exponential, especially in the last 10 years. So,
and you never know where those seeds are going to fall.
That's right.
To give you an example, I went to a student conference once, and lunches were like 3-hour ordeals because so many people wanted to talk about this. And I can remember several years after this, talking to someone who had just started working in Kansas. And I said, well, how did you end up here? And she said, I had lunch with you in Dallas, Texas, at the medical student conference. And so you never really know where those seeds are going to fall, but you got to spread them as widely as possible, because they come back in ways that sometimes you'll never know, and sometimes you're just blown away when that actually happens.
Yeah. I love the home. I appreciate you inviting me in. I want to hear a little more about your woodworking sometime, and just keep us in your prayers.
Thank you.
All right. Thanks, David.